so we will be talking about eating disorders today, but before we do, just have a couple of announcements to share. Go ahead and go on to the next slide here. Right. So a reminder to call our consult line if you are a primary care provider, you want to talk with one of our psychiatrists or psychologists or one of our care coordinators for advice in helping your patients or youth with mental health issues. The lines are open, and here's the QR code and the number. Next slide, please. We've got a bunch of other activities coming up, one on motivational interviewing at our next webinar, and you can see the various topics for our upcoming Project Echoes, and hope to see you at some of these. You can find out more on our website. Next slide, please. Quick word on our disclosures. We don't have any major financial conflicts of interest, but we do get money from both the feds and the state government. And we do open up the last part of the echoes, for a case discussion. So if anybody has a patient with concerns for disordered eating or an eating disorder of some sort, please let me know. Raise your hand or send me a quick note in the chat. You don't have to have looked it up previously. It's just what you remember and the major questions that you'd like to discuss with this group, including our subject matter experts. It's a great chance to basically for kind of like just the group learning. And you don't have to have things wrapped up in a bow either. This is a great chance to be learning together and figuring things out together. So let me know if you've got a case. Okay, great. And with that, I'd like to introduce our speaker for today, Lindsey Bruett. Briefly introduced herself earlier, but she is a licensed clinical psychologist who consults with families and providers and providers of children and adolescents. Dr. Bruett's areas of expertise include evidence-based treatment and assessment of eating disorders, anxiety, depression, disruptive behavior, trauma, and OCD. She highly values the importance of including family when supporting young people and specializes in parent-based interventions. Dr. Bruett has extensive experience providing care and consultation across the socioeconomic spectrum and is committed to continually striving to reduce healthcare disparities caused by systemic oppression. She loves partnering with all of us providers and families to support mental health. And with that, I'll turn the virtual mic over to her to talk about eating disorders.
Thank you so much, Joanne, and really nice to see folks today. Thanks for joining in the midst of your busy days. Let me see if I can advance our slides here. There we go. So you all probably know eating disorders are serious business. They're the second most deadly of the psychiatric illnesses, recently surpassed by opioid use disorder. There are some myths that unfortunately have persisted about eating disorders that have really negatively impacted folks' ability to get the treatment that they deserve. And so one of my goals today is to hope to dispel some of those myths. And so I invite folks to think about, when you sort of think about eating disorders and you maybe think about how they've been portrayed to you in the world around you and in culture and media and movies and things like that, what comes to mind? And I invite folks to put in the chat sort of what are those sort of stereotypical images of somebody who might develop an eating disorder that come to mind.
So you can throw this in the chat or you can unmute and talk too. Either one works.
I guess what comes to mind for me is typically a female or a young girl is a big one, but we know that that's not true.
Absolutely. Yes. Often females, young people, Karen Carpenter. Yes, that comes up a lot. Thin white women. Yes, absolutely. Often of sort of like middle socioeconomic or upper middle class backgrounds. And we know that this is actually, certainly those folks develop eating disorders, but the idea that they sort of are more likely or the only folks who develop eating disorders is actually untrue. And we'll talk more about that today. So this first one is really important, and that is that eating disorders present at any weight across the spectrum. And actually, when we look at the population of folks who develop eating disorders, only about 6% of them are in bodies that are thin appearing or would fall in the underweight category, looking at CDC BMI percentiles. And so if we're only looking for sort of folks that are thin appearing, we're really missing actually most folks with eating disorders. Folks don't choose to have eating disorders. They're really biologically influenced. we're learning more and more about the genetics of eating disorders. A lot of this work is coming from Dr. Cindy Bulick in the Southeast of the United States. And she's sort of been the first to do large-scale genetic studies of folks with eating disorders and discovering that there seems to be shared genetic risk for eating disorders, risk for anxiety disorders, which makes sense. Other family history of eating disorders, which also makes sense. But interestingly, certain metabolic conditions, which suggest that there might be something physiologically different about the way that folks who are prone to develop eating disorders process nutrition. And then also things like school achievement, perfectionism, those sort of traits that we can see going along with eating disorders sometimes. So I expect we'll learn a lot more about that over the next decade or so. We are lucky in the work that we do that often folks with eating disorders have people who love them. They might be parents, they might be spouses or partners, and those folks are crucial allies in treatment. And we'll talk more about why that is. We have unfortunate traditions, I would say, in our mental health field where we have tended to blame parents, particularly mothers, for certain mental health conditions. We blamed mothers for schizophrenia, for autism. We now know really clearly that those things aren't true, but we've been slower in the eating disorders field to kind of get the word out there that parents, we really don't believe that parents cause eating disorders. And that is true, that we do not believe parents cause eating disorders. They're sort of a complex set of genetic and environmental risk factors, and we really need parents to feel like they're the allies in treatment that they are. And then finally, that folks can make full recovery. And the best predictor of full recovery is early intervention. And when folks have fallen off their growth curve, getting them back on their growth curve as quickly as possible. When we talk about eating disorders today, we're going to focus on these. There's a couple others that are in our statistical manual, namely pica and rumination disorder. We really rarely see those clinically, so we're not going to focus on those today. But these are the eating disorders that we tend to see in our clinic and are going to talk about today. One that I really want to highlight is the second one here, and that's called atypical anorexia nervosa. Folks may be familiar. So this is when somebody meets all the criteria for anorexia nervosa, except for their body weight compared to the general population is not considered to be in the underweight range. And so this might be somebody who started in a larger body and has lost a significant amount of weight. And we know that these folks have the same rates of medical complications as folks in smaller bodies, and actually sometimes more psychological complications. And these have been a group that have been really overlooked in both our research and our clinical care. We'll look at some growth charts today to illustrate what that could look like clinically for you all. Okay, so I work with a lot of folks who are working sort of on the front lines, whether it's in primary care, schools, general mental health clinics. And what I always say is that arriving at exactly what the particular eating disorder diagnosis is absolutely not necessary. The good news is that all of the evidence-based treatments for eating disorders have more similarities than differences. And so as long as we know that somebody is struggling with disordered eating and we can kind of figure out the ways in which they're struggling, we can support them. We don't need to know exactly, is this bulimia or is this anorexia, for example. We want to look at behaviors. I would recommend providing initial medical management that we'll talk about in a moment, and then figuring out when referral is needed. And of course, acknowledging that even when many of us know referral is needed, sometimes referrals are not available, or sometimes there's really long waits. And so my goal today is to provide some tools that you can use in the meantime. Not only do eating disorders occur at any weight across the spectrum, but they occur in all groups of folks. So when we look at racial and ethnic differences amongst folks with eating disorders, there just aren't that many group differences. Gender, when we look at gender differences in eating disorders, when we look at the total population of folks with eating disorders, about a third of them are male identifying. So there are more females, but it's not as large of a difference as we kind of are led to believe by the media, as we talked about at the beginning. Thinking about gender and sexual orientation, folks who have minoritized identity in terms of sexuality and gender do have higher rates of eating disorders compared to the general population. And that's likely thinking about sort of that minority stress model, where folks who experience more stress and stigma because of an aspect of their identity are more likely to develop mental health challenges, and eating disorders are part of that. We also know that sometimes folks eating disorder behaviors can serve to affirm some aspect of their gender or sexual orientation. And across socioeconomic status, we'll talk about that in a moment. So what I hope you take away from this slide is just that there aren't that many group differences. The sort of scant research that we have so far, looking at the epidemiology of eating disorders across racial and ethnic groups, shows some trend level differences for some disorders. But my guess is when we have more research in this area with larger sample sizes, all those differences are going to kind of come out in the wash. However, I do want to draw folks' attention to this point on the right-hand side here, is that we are less likely as providers to appropriately screen and refer patients who are non-white. So we come in with our own set of biases, myself included, and that influences who we're kind of asking about these symptoms, who we're referring. And so I try to keep that in mind when I'm coming into clinic and meeting a new patient. Socioeconomic status is not associated with eating disorders. However, food insecurity is associated with increased risk of eating disorders. And that makes sense when we think about one of the biggest risk factors for the development of an eating disorder is dieting or not getting enough food regularly for some reason or another. And so when folks have food insecurity and are kind of faced with sometimes having enough food and sometimes not, that can create that risk factor. Okay, so many of you are pediatricians and medical providers. On our website, thanks to Dr. Yoon, who's on this call, we have many resources, and one of them is a set of tips for primary care providers. This QR code will take you there, but also if you Google CalMap eating disorders, you'll get there pretty quickly. And that is meant to be a user-friendly kind of pocket guide for the assessments that we would recommend that you do in your clinic if you have concern for eating disorder for one of your patients. That also includes our hospitalization criteria and instructions for, if you do have somebody that you think might be meeting hospitalization criteria, you're welcome to call our team at UCSF Adolescent Medicine, and they can kind of guide you through both deciding if there's a need for admission and then that admission process. Okay, so thinking about growth curves, most of you look at growth curves probably very, very often. And so just to orient folks thinking about growth can take many shapes and sizes, but typically we see young people growing along sort of a similar pattern throughout their life, and that's good, right? Bodies come in all shapes and sizes, and we want folks to be developing and growing according to their own genetics and history. And so, none of these growth curves, this is sort of a few different growth curves superimposed upon each other, and none of these are really cause for concern. It can be normal for somebody to grow sort of around the 75th or 85th or around the 10th to 25th percentile. We do get worried, of course, when somebody's falling off the BMI curve. And this is kind of a growth chart illustration of the distinction between anorexia nervosa and atypical anorexia nervosa, and both would be cause for concern. When I think about significant weight loss, we use as a rule of thumb 10% of total body weight as sort of what we consider to be significant weight loss. But of course, any weight loss in somebody who should be growing is concerning and is worth digging into and understanding what might be going on. We can also sometimes see a flat BMI curve, and I can think of a young person who I assessed who was in 7th grade and she hadn't gained weight since the 5th grade. And we know that that's a time period where kids should be gaining quite a bit of weight. There's a pretty big uptick in the growth curve in that middle school period. And so we would consider that to be her body being underweight for her own personal growth trajectory, even though she hadn't explicitly lost weight, just because she hadn't gained weight at the rate that we would expect. Rapid weight gain, obviously there can be many reasons. And of course, there can be many reasons for all of these things. But if we're seeing rapid weight gain, that would sort of lead me to ask a little bit about binge eating. Do you have times where your eating feels out of control? Have you had irregularities in your eating patterns lately? Again, it may not be binge eating disorder, but that would kind of pique my interest to ask more about that. And then finally, even if somebody is growing normally based on their growth curve, that doesn't rule out an eating disorder. In bulimia nervosa, by definition, there's not significant weight loss. an RFID, or avoidant restrictive food intake disorder, which is a disorder characterized by one of three characteristics. So one is low appetite or low appetitive drive. One is really significantly limited food repertoire, like kids who might eat only yogurt and carbohydrates, or a fear of aversive consequences of eating, like really severe fear of choking or vomiting that gets in the way of eating. RFID can cause low weight or weight changes, but it doesn't necessarily. And so folks can certainly have normal growth and also meet criteria for an eating disorder. So really important, I think I'm probably preaching to the choir here because you're all experienced pediatricians and you know this, but oftentimes I'll have people call up to consult with me about eating disorder concern, and they'll have one data point. So they'll know the most recent height and weight at the last visit they saw with their young person. That doesn't actually tell me anything. We really want to look at the history and sort of how weight has changed over time in order to understand whether there might be a problem with weight or a need for weight gain. And we talked about the fact that eating disorders occurring in folks in bodies that fall into the normal or overweight or obese categories, very, very common. That's actually the most common eating disorder presentation. Okay. You all have very limited time with patients in most of your settings, I'm guessing, and you have a lot that you need to squeeze into your visits. These are 4 questions that have been validated to have decent reliability in primary care settings. And so if you're thinking about, particularly with your preteen and teen patients, what you might want to add to your set of screening questions that you ask them at their annual visits, these would be reasonable questions to ask. These are some early signs of eating disorders that would cause us to be concerned. And I want to highlight a couple. So one is in the upper right-hand corner. Certainly many folks become vegetarian or vegan, and it doesn't mean anything about eating disorder. It's not cause for concern. However, it is a common thing that can happen in the development of an eating disorder. And we think that happens in sort of 2 different ways. So one might be, I had a patient who became vegetarian when she was in 3rd grade, and her family was not vegetarian, but they supported her choice. And when I looked back at her growth chart, she was in middle school by the time I saw her, she had started to lose a bit of weight and sort of stopped gaining weight, as we would expect at that time when she became vegetarian. And that seemed to actually be the precipitating factor for the development of her eating disorder, because we talked about how disruption in regular eating, dieting can cause eating disorder in somebody with that predisposition. And so I think for her, because she was living in a family that wasn't eating vegetarian, but she was probably, sitting down for dinner and everybody else was having chicken, potatoes, and peas, and she wasn't having the chicken. She was just having the two other things. And so she probably wasn't getting enough food. We certainly know there's ways to be vegetarian where it's not going to present a problem nutritionally, but I think for that kid it had, and so it's something to pay attention to. And then I think it can happen in the opposite direction too, that folks are starting to develop eating disorder concerns, and choosing to be vegetarian or vegan can be kind of a culturally sanctioned way to restrict food intake. So I want to be curious about that if I'm hearing that, particularly from teen patients. And then another is getting more involved in cooking and baking. And this can be confusing for families, but sometimes, and it seems to be kind of our brain's way of trying to get us to eat. Our brains are evolved to keep us alive. They want us to be fed. And so it does seem when folks aren't getting enough food, they tend to hyper focus on food. And that might come in the form of getting really interested in the Food Network or baking lots of things, but not eating them. When that's happening, I say to the families I work with, if you want to let her bake, that's okay, but she should be eating what she bakes and not just baking it for other people. Okay, so if you have any concern, these would be the areas that I would recommend further assessing. And I want to call attention to the lower right-hand corner. And that is that some folks with eating disorder express an explicit concern about their body or a desire to lose weight. Many folks don't. And we think that sometimes it's an effort to kind of hide symptoms and kind of protect the illness. But we think that sometimes it's really not part of somebody's experience, or at least their conscious experience. And that is okay. They can still meet criteria for an eating disorder if they are having difficulty kind of eating sufficiently and gaining weight in the way that you as their medical provider, their mental health provider are recommending. You work with young people, so you're very familiar with the idea that often when we're interviewing caregivers versus young people, we get kind of different reports, and our job is to triangulate those things to sort of arrive at the truth. These are some examples of typical things that I hear in my clinic about what might be going on for a young person. So it's just another reason why it is really important to get caregiver input when at all possible about what's going on. Okay, so in primary care treatment, I recommend providing education. So the idea that food is the best medicine. If somebody is underweight, the very most important thing that we can do is get them back on their growth curve by gaining weight. If they're eating irregularly, even if they haven't lost weight, we want them to start eating regularly. So 3 meals a day, some snacks, trying not to go for more than 3 or 4 hours without eating, including all food groups, and particularly going back to all the foods that were being eaten before the development of the disordered eating. So sometimes folks in the course of their illness have started to cut out things like sweets or carbs or other things that have become sort of like fear foods. And we want to support families to get back to eating all the foods that this young person preferred prior to the eating disorder. We want to really get caregivers involved. The way that eating disorders operate, and you've probably all seen this clinically, is that it can be difficult for the person to experiencing the eating disorder to feel consistently motivated to want to get well or do the things that they need to do in order to get well. And that's not their fault. It's not because they're bad kids. It's just the way the impact of malnutrition on the brain. And so because of that, we really want to mobilize loved ones to step in and make sure that their young person is getting the nutrition that they need. Of course, monitoring the vital signs, electrolytes, as you normally would. We typically recommend, if you have concern about eating disorder, following somebody at least monthly until they're connected to specialty care, if they're going to be connected. And if they're, losing weight or losing weight rapidly, you might even consider following them as often as weekly, but that would sort of be a clinical consideration. We talked about this, the brain is really impacted by malnutrition. And we do find, which is kind of nice, is that the more nourished folks become, the more easy it is for them to think clearly about nutrition and exercise and things related to their body. But until that point, it's really difficult. And food is kind of the only way to help them get to that place where it is easier for them to think more clearly. We know that there's many ways that we want to support recovery, but weight is a really crucial piece. It's really impossible. I wish that I had a magic wand and I could make it easier for folks to eat sort of from a psychological perspective, and then they could gain weight, but it really works in the opposite way. I need to support somebody to gain weight and be eating regularly, and then their brain has the reserve that it needs to be able to work on body image piece. And not often the body image piece resolves by itself with nutrition. It's kind of amazing. As I mentioned at the beginning, all of the evidence-based treatments for eating disorders have common factors. So the first is weight restoration or stabilization, normalization of eating patterns, working on reducing compensatory behaviors. So making recommendations to families, for example, if you're observing or the family's observing vomiting after meals, we'd want to support the family to make a plan to monitor their young person for about 30 to 60 minutes after all meals. So that might be like hanging out in the living room for homework time instead of the bedroom, to protect the young person from vomiting. And we frame it in that way. We're really trying to reduce blame on the young person and on the family, but really trying to protect them from the eating disorder and support their recovery. Okay, so thinking about supporting families while you're awaiting specialty care for them, or if it's not available, we talked about psychoeducation. Illness externalization is a good way to kind of reduce blame and shame. So talking about sort of like the eating disorder caused him to hide his sandwich in his backpack and not eat it. We're not blaming him for that. We're sort of letting guiding the family to think about it as like the eating disorder is causing their young person to engage in these behaviors that they wouldn't normally engage in. Some details about regular eating, which is really the most important piece here. Our program recommends when weight gain is needed that it occur at about 1 to 2 pounds per week. There's some reputable programs out there that recommend 3 to 4 pounds of weight gain per week. So really, it doesn't seem like you can really go too fast with this. We talked about externalization. We want to kind of, often the eating disorder has caused caregivers to get sort of off balance or doubt themselves in terms of their knowledge about their young person and their nutritional needs. And so part of our job is to help them remember that they have kept their kids healthy all their lives. They know what their young people need. And it is totally appropriate to insist that their young person have their whole breakfast before they go off to school. We're instructing caregivers as much as possible to be monitoring meals and snacks, or putting another trusted adult in charge of monitoring meals and snacks. Sometimes that can be school nurses or counselors or extended family. We know that in the real world, it's usually not possible for families to monitor 100% of meals and snacks. But what I tell them is, like, any percentage they can monitor is better than less. And so an example is, often a family will say, like, well, she tends to like run off to school in the morning. There's not that much time. And so I'm guiding families to try to rejigger that morning routine so that they can monitor breakfast before their young person goes off to school. I think of caregiver-led nutritional rehabilitation as an act of love. Thinking about, if their young person had a cancer diagnosis, the family would figure out ways to get them to go to their infusion appointments, even though that would be not something that the young person really wanted to do and probably quite challenging. But I think about it as sort of like, these caregivers love their child too much to let their health be so impacted by the eating disorder. So thinking about, if you maybe work in a setting where maybe you don't have as much contact with caregivers, or there aren't caregivers available, these would be tools that I would recommend that you could use one-on-one with young people struggling with eating disorders. So thinking about active coping that they can use, distraction, deep breathing, calling a friend, things like that. And I often ask people, what's the most difficult time? Is it before, during, or after a meal? Okay, can you try these skills for the next week, and we can come back and talk about it. Motivational interviewing about how the eating disorder is negatively impacting folks, and then really thinking about reinforcing any small changes that are being made. And this might happen over time. We know that when caregivers are not available to participate, progress in treatment tends to be slower. And so it might be that you're kind of making tiny baby steps in your follow-up appointments with folks, and that's okay. That might be part of the process. Okay. So thank you so much for your attention. These are some takeaways from today, and I will also put up a slide with a link to some resources in a moment here.
Wonderful. Thank you so much for that great talk. And with permission, I guess we can also send some of this out to this group afterwards. We'll switch over to the case discussion now. For this part, I actually encourage all of us to jump onto the